Hello, my name is Mark Ellingson. I'm the hospital partner liaison, likely for your hospital and many hospitals across the state of North Dakota. I work for LifeSource. I'll say a little bit more about that here in a second. And this is a recording. I'm going to turn to my PowerPoint here very shortly about donation education. So what you're seeing is where I work from home, messy as it is. But let me share my screen and we'll go on to talk more about what LifeSource is and how you can help save lives. And by the way, I know this is a recording, but I am keeping an eye on you that you're paying attention. So let me share my screen and start the slideshow. I am Mark Ellingson, MDiv, that's Master of Divinity. Sounds real divine, don't it? And BCC is a board certified chaplain. I'll speak to what that is here in a second. I always think it's good to know who it is that's actually talking to you. Is this someone you want to listen to? And you can decide that. Well, first off, and most important, I'm a husband, I'm a father, I'm a grandfather. Let me introduce you to Tallulah. Right there, she's at a restaurant. She's taking care of the menu for us. Tallulah is just over 2 and kind of a joy of our lives. I also have a couple grandsons, and this is my wife and I, along with Tallulah and the 2 grandsons recently. I'm a chaplain by trade. I was a local pastor for many years. I worked as a hospice chaplain and finally as a hospital chaplain before I came to this position. And as a chaplain, I was a board certified chaplain. That meant that I took 400 hours of clinical pastoral education to accomplish that certification. Clinical pastoral education has a lot of aspects to it, but one that I like to make mention of is that it uses reflective learning. When you go in to be with a patient, it's about the patient and their family. When you step out of there, it's about you. What is it in that situation that triggered me, that made me think, that um, made me anxious? And if we recognize those things, we can work through them. So I just commend that to you. I'll give you that for free. My job again is I'm a hospital partner liaison. Basically, I work with hospitals in North Dakota, about 2/3 of them, to work with education like this, to work through any questions about donation, to do whatever else is helpful to our relationship. I do live in North Dakota, and so this is all driving distance to me. And finally, I'm the father of a nurse. I'm also the father of a high school principal and a statistician and an accountant and an engineer. But for your purposes, it's probably good for you to know that I'm a father of a nurse. I not only worked in the medical field myself as a chaplain, but um, my nurse daughter and I spend a lot of time visiting about various things. She's worked all the way from a CNA to now being a manager to she was in the oncology department, and now she's the uh, a sup- a executive in Ethos Hospice and Home Care. Sorry, but I stumbled over that. It's sometimes you forget the names of your kids. Well, this is a CEU course. If I've either given it to you live or you are watching this with a window of time, 2-3 weeks to watch it and give me a evaluation, that would have been shared with you. The learning objectives are: describe the healthcare professional, that's you, role in the donation process. We're going to identify what organs and tissues can be donated. We will summarize the referral process with in organ, tissue, and eye donors. We'll explain the required documentation and how to complete it, and we will answer any questions. Now, obviously, you're not going to ask them live, but at the end, I will put my phone number and my email, and you can send me a question if you want, or you can talk to your leader, the person that's in contact with me, and share that question, and I will be sure to find the answer for you. Well, I represent LifeSource. The map at the upper right there shows our LifeSource area, the 3 states and a little bit of Wisconsin near the big metros. We are an organ procurement organization. Why don't you practice right now saying Organ Procurement Organization 3 times fast? I have trouble saying it once. These were federally designated based on population. Hence, ours is, as you see on the bottom, they're the second largest by area because our population, especially across the Dakotas and the rural part of Minnesota, is more sparse than many places. There's 56 of these OPOs in the nation. As in LifeSource, we serve about 7 million people, 9 transplant centers. Think about what the closest one is to you when we get around to talking about them. 279 plus hospitals. This is a map of the United States, and you can see us up there at the top. Right up here. This is the only one bigger, the blue that includes Alaska, Montana, parts of Idaho and Washington and Alaska. But we're the second biggest, hence there's much time that we spend in flight, not me, but our clinical folks. And just in our area, there's over 3,000 people waiting for a transplant. This is the mission, vision, and values of LifeSource. Our mission is everyone shares the gift of life. Everyone has that gift, and they use their life as they see fit. And in the case of organ donation, we sometimes can give that gift to other people. Our mission is we save lives and offer hope and healing through excellence in organ, eye, and tissue donation. We intend to be as good as we can at doing this. And we have values that we hope that we show to you very clearly. Respect for everyone, accountability, advocacy. We advocate for patients, life, and innovation. Now, this isn't, I won't show you a bunch of my vacation photos, because who's excited about that? This is the Grand Canyon, and if you've been to the Grand Canyon, you were amazed at it. Now, a picture doesn't do it justice, does it? That's because it's really about the point of view. If you're really there, it's really something. I was just, I'd seen pictures, I thought, and this picture looks very cool. But when I actually saw it and walked up near it, it was just amazing. It's about the point of view. The same is true of other things. This is a wife and her 2 sons, and their husband and father stopped to help somebody, and the chain broke, and without getting very graphic, he ended up with a head injury that he wasn't going to survive from, and he ended up being an organ donor. Horrible tragedy. Their grief is real. It continues to be real. But they wanted the Donate Life flag to be flown underneath the American flag right out where this man lived, and they honor what he did. So in the tragedy, there was something good. It's about the point of view. Let me introduce you to Sally. Sally is a liver recipient. You see that she received her transplant in 2006, according to her shirt there. At that time, she was in her 60s, and she received a donor from a donor that was 82. Now, she would tell you, if you could hear her story, and if you ever have a chance, please do, that she has 3 grandchildren that she'd have never seen if she hadn't got this transplant. It's amazing to her. And by the way, her liver will be 100 in April of 2023, and I'm recording this just ahead of that. So we're looking forward to doing a party to celebrate. So donation on one side has tragedy, on the other side has joy. Our hope is the same as your hope. We celebrate when patients and their families, they find recovery, because that's life. We hope all of your patients go on to live, but we know that's not always true. And our hope is, along with your hospital and LifeSource seek to save lives and offer hope and healing through excellence in organ and tissue and eye donation when a healthy recovery is not possible. If someone gets better, we celebrate it. When someone does not, we grieve, but we celebrate if they can also be a donor. We come from the same place. Now, 2022 was a record-breaking year. You can see down here there were 222 donors. The 244 on the very bottom, that's people who intended to donate, and for whatever reason it didn't work out. We still consider them donors. Perhaps when the operation to recover the organs started, they found that there was metastasized cancer or something else happened. We consider them still donors because their intention was to donate. There were 760 organs transplanted from that. That's a 33% increase. And that's just in our area. And 1,058 tissue donors, 23% increase. And I want you to see this little number, 80,000 plus lives potentially impacted by those donors. And we'll talk about what specific tissues can be donated. And so it's a big deal. Some more numbers. Up on the left, by the way, that's our new CEO, Kelly White. She was from Hennepin County in the cities, but she comes to us with a passion for donation. 136% increase in hospital partner liaisons. Again, that's what I do. And that was so we could be more present more often in our hospitals, to have more people to do that. We've supported about 1,400 families by aftercare. In Minnesota, 260 Minnesota driver's license offices received new awareness materials, and we work with the driver's license offices elsewhere too. 400 plus donor families attended gatherings in North, South Dakota, and Minnesota. We had flag raising ceremonies, and some of you perhaps are doing that not long after I'm recording this. 91,000 people read the What is a Coma versus Brain Death blog article. We do blogging. And in the nation, there was the millionth transplant celebrated. Since 1988, this was the millionth transplant. That's just some numbers. Here's some more numbers, but different. Here's a little 4-letter word I want you to memorize: rare. If someone talks to you about donation on the street, remind them donation is a rare event. In 2022, we received nearly 30,000 total referrals. Those are referrals, either someone that was triggered and they were had a major brain injury and were not likely to survive, but most of these are deaths. And even the first category I mentioned, those people were going to be dying in all likelihood. Rarely something else happened. Of those, 3,600 were vented referrals. To be an organ donor, you must be vented. And then we go down to 555 potential organ donors. These were people that actually had potential to be an organ donor, and then only 244 of those were actually made the decision to or had been donor designated to be an organ donor. And so from 30,000 to 244 for donors, organ donors. It's rare. On the other side of that, from that 30, it goes down to 2,500 potential tissue donors that could have been a tissue donor, and actually 1,000 of those became tissue donors. And you see the potential healing. But again, rare. There's stringent rules, and so it's not very easy for someone to be able to be a donor at all. So fewer than 1% people die in such a way that they could be a donor. Okay, let's make my thing work here. There we go. Hope you can see these numbers. I said that there was about 3,000 people in the upper Midwest already that need life-saving transplant. In the nation, it's about over 100,000. It never seems to get under 100,000. Every day I could go in and look, and it's 106 or 110 or 104, but we're never getting under 100,000. We want to someday. Every year, roughly 10,000 people end up becoming donors in the United States, 3,000 in our area. The entire recovery process takes about happens in about 48 hours or less, and we're working on ways that would become even quicker to have happen. On the other side of this are numbers that are kind of very negative, some of them. Every day, 22 people die while waiting for a transplant. This has to do with this 100,000. Every day, 22 people off of that list die. Every 10 minutes, a new person is in need of a transplant and are added to that list. Every 10 minutes. So in the time that we're doing this, 5 or 6 people will be added to that list. One donor can save up to 8 lives through organ donation. Now I want you to think for a second, because in a minute or two, I'm actually going to ask, what organs can be donated? That's different than tissue, and that's different than eyes. And we'll talk about the tissues and eyes too. But what organs can be donated? There's a total of 8. And again, only 1% of people actually qualify to become a donor after dying. This shows the organ donation process. Somebody might think it's real simple. You just show up at the hospital, something happens. No. A person is admitted to the hospital, probably with a major brain event, a trauma, but other things can be. The triggers for a consult are met. The triggers would be something that shows that they've lost some of their brain function or other things, and then we are consulted. That just means that we're going to follow this person. This is in an ICU. That consult to LifeSource. Once they're triggered, they consult LifeSource, which just means that they call in and explain. And we do an initial evaluation of that consult. Out of that initial evaluation, many are found to be, this person doesn't have potential to be an organ donor. It could be a combination of a lot of things. They're older and they have infections, they have various comorbidities and so on, and they all add up to saying this person couldn't be an organ donor. That's why it's rare. If out of that initial evaluation comes daily follow-ups, if there's a consult in a hospital that I serve with an ICU, I will daily follow it up, or somebody from LifeSource will daily follow up, not with the family. We're not talking to anybody yet, just to follow up to see how things are going. We're watching in the background. Then on-site triggers might be met. Those might be that the family is deciding they want to make end-of-life decisions. They want to withdraw the mechanical support. Then we might come on-site to meet with the family should that happen. We don't influence that decision. We just respond to it if it happens. Once we're on site, we huddle with the care team. We like to have the doctor there. We certainly huddle with the bedside nurse and others that are part of this to just discuss what's going on with this donor and with this family, with this potential donor and family. Then there might be a donation discussion with the family. We like if the bedside nurse can be there. We'd love to have the bedside nurse there or others as we have that discussion about what possibilities are now that they've made likely end-of-life decisions. If there's a positivity to go ahead, then there's donor management evaluation. We work with the donor to manage and to evaluate everything that's going on, evaluate all the organs. There's sometimes biopsies taken. There's sometimes a check of the lungs, various things to just see what's possible. Out of that, once a match is found, the procurement surgery for an organ will take place at the hospital, and then there's aftercare. Now, this is the organ donation process. The tissue donation process will be just a little bit different. Now, that was just to show the process. Let me stop for a second and just talk about what our strategic plan is, because part of it has to do with this. Part of our strategic plan, half of it is to save more lives, to do whatever we can to increase organs transplanted and also to increase tissue donation. We're going to try to address, for example, transportation challenges. And I'm not going to read all these little things. I just want you to know that's what we're doing. We want to save more lives. And we want to advance an equity, diversity, and inclusion in our area. That's both in working on our own people, have our workforce recruitment to be more diverse, to expand our education and development, but it's important for us to reach out to a varied number of people and to be able to respond to them in a way that's positive. To work with hospitals, now the hospital collaboration model is especially for the bigger hospitals that have an ICU, and we come to the hospital to collaborate with them, and people like me come there kind of regularly. We'll follow up on referrals. We might review the census to see if there's any questions about anybody. We want to make connections with the care team. I really like getting to know nurses from all the hospitals, whether it's my smallest ones or my bigger ones. And this collaboration helps us to see how the family dynamics are, so that should we ever have to work with a family, we can understand what's going on with them. I appreciate your collaboration with me to ensure the best outcomes. Okay, let's get back to the donation thing. Organ donation. Who can donate? Well, everybody's eligible in one sense, but not everybody has real genuine potential. To be an organ donor, you must be mechanically ventilated with a heartbeat at the time of consult. You must be. You can't suddenly decide to be ventilated after you haven't been for a while. Recovery takes place in an OR through evaluation, after thorough evaluation, during which time the patient remains in the ICU and remains ventilated and supported in robust ways. The recovery is performed by transplant surgeons, though I should say LifeSource is hiring a transplant surgeon so that we can do this without making the transplant surgeons have to do as much traveling. Once removed from the body, gifts must be transplanted within hours. A kidney perhaps can stay out of the body for 24, a heart maybe for 6. And the ages, 0 to 100 plus. Then there's tissue. Tissue donors have already had cardiac time of death. Now, of course, the organ donor as well, but the organ donor we may be working with the organ donor up until they remove the mechanical ventilation at the request of the family, and then there's possible donation. But tissue donation means they've already had a cardiac time of death, and that's been called into us. The recovery needs to take place within 24 hours of death, but we like to be called within an hour, just so that we can evaluate things. The recovery is performed by highly trained LifeSource team members that will either come to your hospital, or the donor may be transported to our facility in the cities. But I'll talk about that here in just a minute. These gifts can be preserved and stored for an extended period of time if needed. Some gifts of tissue can be stored up to 5 years, ages 0 to 100. To put this in greater context, the oldest organ donor I'm aware of was 92. Tissue? Well, there was an eye donor that was 107. Now, think for a second, and we'll answer it here with the next slide. What organs can be recovered? Typically, when I ask that question, I get 6 quick answers and then 2 organs that we have trouble thinking of. And the same thing, what tissues can be recovered? Okay. You had this in your mind? Let's see what the answers are. Okay, here's the organ donation process. 8. Here's 2 lungs, and now down here are 2 kidneys. So that's 4. A heart is 5, a liver is 6, and that's the 6 that people get. People forget about the pancreas, which, by the way, is often transplanted along with a kidney, perhaps for a diabetic. And this is the one people don't get very often at all, is the intestine. Now, that's a very rare thing. I think last year we maybe had 2 of those, but it does happen. That's the organ donation. Tissue in this other color, the heart valves might be recovered if the heart itself can't be used. Corneas and sclera, and we're going to talk about eye in a little bit. Bone marrow, skin is commonly collected, connective tissue, tendons, veins, and bone. Let me go back just for a second to connective tissue. A person named Lori, who does the same job I do in Minnesota, she lost her son in his 30s to a accidental overdose. And she, like every mother would, mourned him greatly, but found just a little bit of solace in the fact that he had decided previous to this time that he wanted to be a donor should anything ever happen. Well, it turned out that once this happened, he was able to be a donor. About a year after that, she was with her family snow skiing, and I'll often ask groups I'm with, anybody here snow ski, ever crashed? Well, this my partner, my colleague here, she crashed, and I saw her PowerPoint in which she shows herself on a gurney on the mountain. If you're on a gurney on the mountain, you know things weren't good. When she met with the surgeon says, "Wow, you really wrecked your knee. You need a," that's the word, transplant. And she got to thinking, I wonder about my son's stuff, my son's tissues. And a second surgeon was able to actually go and check, and it turned out that her son's tissues hadn't all been used by that point. And she was able to get some connective tissue in her knee transplanted into her knee from her son. And so she now walks every bit as good as you or I with a part of her son in her knee. The joy side, she got to experience both the joy and the tragedy of transplantation. Potential organ donors come to us through 2 paths. The destination is the same, but there's 2 paths. There's a brain death examination, likely, and that in this case, on the left side, that exam is consistent with brain death. Now, this is a clinical diagnosis. It's based upon very specific clinical procedures. It probably includes an apnea test. It includes other kinds of tests to show that the brain is not just injured, but it has died. Because of that donation is discussed with family, whether donor designation is disclosed or they seek authorization from the next of kin. The patient is supported during organ evaluation and allocation process, but remember, this person, time of death was when that brain death declared him or her as having died. That deceased patient is transferred to the OR, still intubated, and the surgery recovery begins in the OR. The other pathway is donation after circulatory death. You might hear me refer to it as DCD, sometimes called donation after cardiac death. In this case, the brain has not died. There is probably major injury, but there is still electrical activity, there is still blood flow. The family and the MD initiate the topic of withdrawal of medical treatment. This is never initiated by LifeSource, only by the hospital. The LifeSource coordinator will have a discussion with the family if that topic has been approached. And if the family is supportive of donation, or if they're donor designated, they get evaluated for potential DCD, donation after circulatory death. We may seek authorization, or there may be donor designation. The patient is supported during organ evaluation and allocation process. The withdrawal of support, remember, this person is still alive. The family has seen that Uncle Fred doesn't want to live like this. He's really not living, and so we want to extubate. But that extubation, withdrawal support, happens in the OR. And the pronouncement of death in the OR is made by the hospital. And after a 5-minute wait, the family is, at the time of death, is ushered out of the OR and the surgical recovery, the transplant surgeons come in to the OR. So you see the two different ways. Brain death and coma are not the same thing. In brain death, all brain tissue is dead. There's no electrical activity and there's no blood flow. In a coma, a portion of the brain is injured, electrical activity can be detected, and there is blood flow. Brain death is not coma, but it looks like it because the patient looks like they're sleeping. Their heart's beating, their chest is moving, they're warm, they have color, and everything continues to be monitored. It doesn't look any different than before the brain death testing, but sometimes the blood flow test, for example, can show that the brain tissue has died. COVID, isn't that, it should be a 4-letter word because we just hate it. COVID is not a rule out anymore, and I'm not going to say much more than that. If you have a patient that has COVID-19, call them in if they die, call them in if they are triggered in an ICU. They can be potential donors, and we'll test them again. Organ donation is an opportunity, is a transplant surgeon dependent question, and tissue and eye donation is also an opportunity at times. We'll screen all referrals regardless of their health history. COVID is certainly a factor, but it does not rule out anymore. Let's talk about registration just a little bit. Minnesota, South Dakota, North Dakota. If you have that little heart down there, I had somebody ask me, does that mean that I'm willing to donate my heart? No, that's really you're saying you have said that I am willing to be a donor and donate whatever. Donor designation, or as it's usually called now, first person authorization, is giving permission to save others through organ, tissue, and eye donation. We can document that on our license. We also can be put on the registry list by going on websites and do that. If you make that decision, that is a legal decision. It comes under gift law, and it's the national law says that if you make that decision, it cannot be unmade by anyone except you, even once you're no longer able to make decisions. It's been made. It's a decision that you've made, and LifeSource and hospitals will try to respect the voice of the patient. When we discuss with families about their loved one, we like to have a collaborative discussion. That is, we really just as soon have someone there. A couple of things about that. Research shows that the next of kin are less likely to say yes when a non-OPO personnel approaches them. When a physician or a nurse approaches them, they begin to question whether every effort has been made to save their loved one. You at the hospital are there to do everything you can to save them. It's the OPO can talk to people. Once that ability to fix things no longer is available, we try to fix it. And some families who said no expressed decision regret following their loved ones. They needed more time to consider their decision, and they wish they'd considered it more. When we have collaborative donation discussions, that means that we in the hospital, I and you, are on the same page. Families feel reassured that the healthcare providers did a high degree of medical care and effort to save their loved ones. They ask more questions, and they can process information better. When there's a little bit of time, and it can't be tons of time, but a little bit of time between learning about death and learning about donation. There's improved rates of authorization when there's a separation between the notification from a doctor and acceptance of death and request for donation from us at LifeSource. And it's also an increased authorizations with a collaborative approach by OPO coordinators and hospital care team. We are partners. We feel that way. We hope you feel that way. How do you connect with the family? When the family is eligible to be a donor and is registered to be a donor, you might say your loved one has made the decision to be a donor. We partner with LifeSource, the donation agency, and they'd like to speak to you now and review the next steps. When the patient is an eligible donor and does not have donor designation, your loved one may have the opportunity to be a donor. We partner with LifeSource and they'd like to speak with you. When donation discussions occur, if you are able, please be there. You're the face that they know and the face that they trust. If the family's not ready to speak, it's okay. Get a phone number where they can be reached and we'll call them when they want. And if they say, no way do I want to talk to LifeSource, well, we won't put them in a corner. We'll say, okay, can you just give them a phone number? And if they change their mind in the next few hours, call us back. I want you to meet Nehemiah Larimer, who was an organ donor, became an organ donor just prior to graduating from high school in 2015. Below, this is his mom, Emily. She now does what I do at Monument Health in Rapid City. And this is someone who received one of his organs. And you can tell that she's not actually listening to his heart. But it's to show there's this connection. That's really cool. Potential donors must be ventilated in order to be a donor. Organ donor, collaboration and care for the family is extremely important. It's really why Emily came to work with us. And communication with the hospital care team, that's you, and the transplant surgeons is crucial. We're all partners together in this. Here's the trigger card that an ICU would have. And I try to see that my ICU has all that they need of those. A ventilated patient that's lost 2 or more brainstem reflexes. If I was with you, I'd say, name some brainstem reflexes. And you probably can name several, pupillary reflex, pain reflex, overbreathing the vent, those kind of things. You lose 2 of those, please call in. Prior to end of life conversation, call in and let us know that's happening. If there's anticipated withdrawal of life-sustaining mechanical support, call it in. If the family mentions donation, we'd really like to talk. We want to answer any questions, even if that's not going to end up being a donor. We want to answer their questions. And obviously, always call with cardiac death. In 2022, the age requirement for making a referral changed from 20 weeks gestation to 36 weeks. The transplant surgeon said it's too small. It's a recent change. So if you happen to call in earlier, no big deal. Our folks will say, and if you're going, it's 35.5 weeks, should I call or not? Just call in and see, and we can answer that question. DCD and family, if the family requests to be present in the OR, there's compassionate draping. Behind this blue sheet are the surgical tools. And so the family comes up and they can be with their loved one, hold their hand, talk to them. When I've been with them, there's been telling stories and laughing and crying. Last year, about 29% of our organ donors were DCD. This just shows you in an organ donor, all the people that are involved, anywhere from the RTs to the pathologists. And then there's the teams that come to recover, the funeral home, the shifts, the family pastor, the chaplain. There's all sorts of people. This is a major, major thing where we all work together. How do we find this match? Well, typically the match is found. The donor information comes from the hospital and from LifeSource. It goes to UNOS. The recipient information comes from the transplant organizations, and that goes to UNOS, and they find a match. And then these 2 groups talk to each other. And sometimes the transplants say, we're interested in those lungs. Can you do a check on them? Can you do a biopsy of the liver, so on? And that's how these things go. But UNOS, United Network for Organ Sharing. After donation, often there's a way to honor the donor. A moment of silence, which is kind of a misnomer because it's really a moment where they read what the family had to say about someone. The family writes this. Uncle Joe loved to fish and liked to tease kids and liked to sing in the choir, whatever it might be. And we read that so we remember that the person with whom we're working is a person who was loved and loved. If there's an organ donation, there's often a flag raising at the hospital and a flag raising ceremony if the family wants to just acknowledge that this happened. This happens to be at Avera there. And this would be a walk of honor on the right. the family and the donor is on their way down the hallway to the OR where the procurement of organs of the gifts will happen. And these people, staff, are all out there to honor that donor and family. Tissue and eye donation. It's also a process, and that's what this little thing here says, but I'm going to talk more about this side. At LifeSource, and I'm going to read it, screens, recovers, packages, and ships donated tissue and corneas to processors. Sounds very mechanical, and it really is. We recover these things, and then we send them to these partner organizations who process this donated tissue into usable grafts that are distributed to surgeons. And there's over 1 million tissue transplants performed every year of various kinds. The process is not so different from organ, except that the referral comes to us, in this case, pretty much after death. The hospital contacts LifeSource about potential for eye and tissue donation. If we have access to your EMR, that even helps, but in many small hospitals, we don't try to we can't possibly keep up with all of them. We'll talk when that referral comes, we'll talk about it. And if out of the visit, we ask questions and we ask more questions, and if you called in a referral like this after death, the more questions we ask, the more possibility there's a potential for donation. If there looks to be real potential for donation, then we'll talk to the family. And again, we'd love to have you there if you can be, but oftentimes in this case, the family after death has already gone home. And so we need to talk, we'll end up talking to them on the phone, but we really would love to have you a part of it if we could. We'll begin to manage and evaluate. We'll review medical and social history. We'll ask the family all kinds of questions, all the questions you get asked when you donate blood and more. We'll conduct infectious disease testing as necessary, and we'll coordinate with the medical examiner and funeral home. I'll say more about that here in a second too. We'll match donors with tissue processing partners because the various partners do different things so that we can maximize the donor's gifts. Tissue and eyes are recovered by our team and sent to processing partners, and we will follow up with them in an ongoing individualized care to the extent that they want it. Tissue, 90% of donors can give bone. Now, we don't typically, it's rarely does happen, but rarely do we take a whole bone to put into another person because they don't fit exactly. Bone is typically taken and used as a piece. Sometimes it's ground up and mixed into a paste to repair things in another person. Orthopedic, spinal, reconstructive. Connective tissue, I already talked about my colleague who received that. Joint reconstruction, bladder and uterine slings. Heart valves can be used when the heart can't beat. And the first word there is kind of a tragic one, children. Children, sometimes there are children on the list to need. And when they need a heart valve, the tragedy is it has to come from another child. An adult heart valve wouldn't fit. These heart valves from a human work much better, have better function than the mechanical valves we used to try. Saphenous and femoral, these are for bypass or dialysis shunts. And you notice the part here where it says male donors. If I was with you and I would look around and see if there was a guy there, and then I'd say, well, the reason that is us guys have thicker heads and thicker veins. These are easier to deal with because males tend to be thicker and easier for surgeons to deal with. Skin, 40% of donors. Burn victims, hernia repair, reconstruction following mastectomy. Wound care uses lots of it. Eyes, restore vision, enhance vision. Research. Sometimes there's opportunity to recover some things for research. That can be organs occasionally for research. If that possibility exists, that question will be asked the family separately. They can say yes to donation, but no to research. And if a whole eye is used, that's recovered for a research thing. Typically eyes, it's the cornea, and only occasionally the white or the sclera. here is the cornea. And the one thing I didn't know before I became this is that the corneas, as it says on the bottom here, are the most transplantable human tissue. And that's because that has no blood vessels. So matching a donor to a recipient is not necessary. It can be with a segment of healthy, it can be replaced in whole or a segment of healthy cornea to allow those maybe who even are corneal blind to see. It's an amazing gift. If there's going to be an possible eye donation, this may be in your hospital policy, or our donor coordinator can talk about it. You elevate the head above the shoulder about 30 degrees. You gently close the eyelids. Use paper tape to keep the lids closed and prevent the corneas from drying out. Apply light ice packs or ice-filled caregiver gloves over the closed lids. Never use commercial ice packs. If I was with you, I'd say, why is that? Can you think why it is? Yeah, you got it right. Commercial ice packs are too cold. They'll freeze the eye. Now, autopsies do not rule out donation. We work with the medical examiners, and most of the time, almost all of the time, we can work through donation by either we take samples for them, take pictures for them. Sometimes in the cities, the donation will actually occur at the medical examiner's office. Or sometimes they can do an autopsy, and then we can recover especially tissue later. This would not be organ. Organ can only be worked out when we can work out with them for the medical examiner to do the autopsy formally after the donation process is over. And usually we're able to work that out. We do everything we can to work with them. But in a medical examiner's case, they are in charge. But we work with them very well. When donation proceeds, follow the hospital policy for completing the death record. You probably have a checklist. Just go through your checklist. We need a proper ID band for donation to proceed. We need to be able to say, this is who this says it is. And so if they've lost their band, they need to have one before we see them. We need to note the outcome of the donation evaluation on the death record. Patient died, life source was called, they deferred because of infection and age. The patient died, we called, they weren't donor designated, they talked to the family and the family said no. Patient died, we talked to the life source, there was potential, they talked to the family, and donation was going to proceed. Just real general on your death record. Note that referral number on the death record, which is a 6 digits, which are the date. If you look at it close, dash, and then it's the number of referral in that day. Notify the funeral home that donation will be taking place. Please talk to us so that our person can say, hey, please hold that body because there's potential for donation. We don't want the funeral home to rush over and find out that they have to wait. And if necessary, we'll call the funeral home. And then following collaboration with LifeSource, let the funeral home, they will be contacted when donation is complete and the body is ready for release. And that should be our responsibility to do. Most of these folks will be tissue transfers. I want to go down to the middle here. In 2022, over 90% of all tissue donors in Minnesota and North Dakota were transferred to Minneapolis. This is our surgical suite. We actually have 3 of them. And it actually isn't taking more time. A funeral director trade service comes to pick up the patient, the donor, takes them to the cities, waits for them there. We have all our things ready there, and it can do this very quickly, and then brings them back to the funeral home, and then we should notify you as well. It's probably almost quicker than us trying to fly out several people and all of the stuff that they need to do this at the hospital. And it also means that we don't try to clog up ORs. Organ donation still occurs at the hospital OR. but this is tissue donation. And the medical examiner cases, we still work through them, and sometimes we even recover at the medical examiner's office. This is our office in North Minneapolis. You ever want to see it, let me know. And I will, and you're in the cities, and I'll see if I can arrange that you can just come and take a look at that up to and including the surgical suites if they're not being used. We have a outdoor garden, a memory wall. We're right near the river. And it's a beautiful place. And in the community, we weren't far away from where the George Floyd murder happened. And so at that time, we really closed up the place for a little bit during the immediate aftermath of that. Once again, we want to reflect the diversity of our communities by 2025. And you see this with the authorization rates. The American Indian, Native Americans, only 25% authorized, Asians only 18%, blacks 45%, whereas whites go 65%. And our medical history, the way the medicine has treated people, has caused us a little bit. And we're doing all we can to engage with these groups. Let me introduce you to Grayson. He's a young man that received a heart transplant when he was about 2. He was part of the Turtle Mountain Band of Chippewa, and out of that heart transplant came his grandmother in particular began to work with us, and worked with the tribe so that they now can put donor designation on their tribal IDs. They call it Grayson's Law. We go to listen and to do what we can to engage with the various community groups that exist. And oftentimes in North Dakota, it is our native populations. There's some myths about donation. These are actually taken from a poll of people. Sometimes people are allowed to die so their organs can be taken. No. First of all, it wouldn't work. Plus, it's unethical, and that's just not the way we do it. If I agree to donate my organs, the hospital staff won't work as hard to save my life. No, again, it doesn't work for one thing, and that's not the way it is. You all work as hard as you can. It's only when it doesn't, when there's no longer can be fixed, does donation become part of it. Maybe people really believe this. Maybe I won't be dead when they sign my death certificate. No, that's not true. That's very carefully watched. My religion is against organ donation. I know of no organized religion that is specifically against organ donation. Someone asked me, what about Scientology? I looked it up. Scientology says when you've died, you can do what you want with your organs. Somebody said Jehovah's Witnesses because they don't want to have blood transfers while they're alive. Well, they're all right with organ donation after death. If they were going to receive organs, they would want them to be drained of blood before they actually receive them. I'm too old to donate. Well, I'm fairly old, but I think they take some of my stuff. Like I said, the oldest organ donor I know was 92. LifeSource will pressure the family to donate. No, we will not. We're trained not to do that. Moreover, it doesn't work. Here's some questions. I'm going to go through them quick. True or false? If there's going to be an autopsy, donation cannot proceed because of timing. That's false because we can work with the medical examiner. True or false? A proper ID band must be issued and placed on the donor. Donation cannot occur without it. Yep, it's true. True or false? I should call the funeral home before I call LifeSource to give them a heads up about the death. I think the key word here is before. Call us first so that we maybe can even say, yep, not going to be donation in this case, just go ahead and call, or we need to call the funeral home and say there's going to be a delay. We're holding this body while we consider. True or false, all hospital deaths must be referred for screening for donation potential. I don't think I said this earlier. That's actually a national law. All hospital deaths must be referred to LifeSource. So please call them and try to call them in within an hour. There's an age limit when considering organ and tissue donation? Nope. Age is a factor, but it doesn't settle things. Organ and tissue donation are rare opportunities. There's that 4-letter word, and it's true. Rare. The donor coordinator from LifeSource will inform you if donation opportunities exist. That's true. They may have to ask a lot of questions, but they'll be the people to say whether there's an opportunity, and if there is, what's the next step. If the deceased qualifies to be a donor, the donation coordinator from LifeSource will attempt to speak with the family. Yes, we will. We'd love to have you with if you could be. True or false? True or false, pardon me. True or false? Heart valves and connective tissue are examples of life-giving gifts which may be donated. Kind of an obvious question, but absolutely. True or false, eye donation may be possible even if a patient has cancer. I didn't say this specifically, but remember I said there's no blood vessels to the eye, therefore cancer doesn't affect the eyes like it would other things. In fact, just don't assume anything about cancer, COVID, HIV, or anything. Call everything in. Now, what questions do you have? If you have a question, you can, I'll show this here at the end again. My email or my phone number. But do remember, from death comes life, from tragedy comes joy, from despair comes hope. LifeSource.org will have a whole bunch of resources that you might be able to do, including very interesting stories. And there's my information. Hey, thanks for taking the time to listen to this. I hope you learned something. If you're eligible to get a CEU, please fill out that evaluation and get it back to your leader or send it to me. And please let me know of any way I can be of support or help to you. I appreciate being able to speak to you and look forward to a time when maybe I can see you face to face. Many blessings. Thank you.